So hi, everyone. If you don't know by now, my name is Sarah Eisinga, and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And I'm pleased to welcome all of you to today's first educational session, which will focus on COVID-19 and vaccination update for lymphoma and CLL patients. We appreciate that so many of you can join us online today. The COVID-19 pandemic continues to bring challenges to lymphoma patients across the country. Whether you're newly diagnosed, a caregiver, or a cancer survivor, this session will provide you to the most up-to-date information on COVID-19 relevant to lymphoma and CLL. This presentation will cover immune responses, vaccine availability, prevention, and treatment options of COVID-19. Now, before I introduce today's speaker, there are a few things I'd like to bring to your attention. This session is being recorded, and the recording will become available following the conference. You will receive an email when the recording becomes available. At the end of the presentation, we'll leave a few minutes for the Q&A period. So you can ask your questions by typing them in the questions box located in the middle black toolbar at the bottom of your screen. We'll try to answer as many questions as possible. I'd now like to introduce and welcome you our speaker, Dr. Nathalie Johnson. Dr. Johnson is an associate professor in the departments of medicine and oncology at McGill University. She performs translational and clinical research at the Jewish General Hospital since 2010. She established a lymphoma tumor bank that she shares with other investigators to advance biomedical research in Quebec and Canada. Her translational research focuses on identifying mechanisms of therapeutic resistance to conventional and novel therapies, including immunotherapy. She is the primary investigator of several clinical trials that test novel therapies in patients with newly diagnosed or relapsed lymphoma, and she's the program director of the clinical investigator program at McGill. Thank you very much for joining us today. You can start sharing your slides and do your presentation, Dr. Johnson.
Can you see this?
Yep, it's good with me.
And can you hear me?
Yep, I can hear you okay.
Excellent. Well, thank you. Thank you for joining, and thank you, Lymphoma Canada, for inviting me to speak today. Here are my disclosures. I have worked as a consultant for many pharmaceutical companies, but none of them are very relevant to today's talk. So today it's an honor for me to talk to you about COVID-19. I've been exposed to this in my clinical practice with patients with lymphoma, and I've done some research on it over the past couple of years. And today's an opportunity to learn a little bit about how your immune system works in normal people and in patients who have lymphoma and CLL, to understand the impact of COVID-19 on patients who have CLL and their immune response. I'll discuss the new vaccines that are available to us now, and give some updates on the treatment possibilities. So to learn about the immune system, I think it's best to learn about it in the context of normal. So your body is designed to fight infections, and there are two compartments that are responsible to do that in your immune system. There's one that is meant to produce normal immune cells and have them mature, and that's the bone marrow. And then there's another compartment called the lymph nodes and the spleen that are there to help produce the immune response. And both of these components, both of these compartments, I mean, you can appreciate are impaired or can be could be occupied by patients with a lymphoma. So they're both compromised. Within those two compartments, there are different immune cells. Within the marrow, there are immune cells that are important in fighting acute infections, like bacterial infections, for instance. So if somebody cuts their skin, the immediate response would be for neutrophils to travel to the site and prevent a bacterial infection. Then there's a more adaptive immune response that takes days to acquire, and those cells that are important in that immune response are called lymphocytes, and there are two types of lymphocytes: B cells and T cells. The B cells are there to produce antibodies, and T cells are there to produce direct killer type cells that will destroy infected cells. So in the case of COVID, for instance, the B cells are important to produce antibodies. T cells are important to kill the infected cells. And you can appreciate that in patients who have lymphoma or CLL, the marrow may be compromised, and they have decreased immunity by having fewer neutrophils, fewer B cells and T cells. And this could be in the context of just, being on observation without therapy, before therapy, and even after therapy. So in people who are exposed to a virus for the first time, it's an orchestrated event, meaning that there are multiple cells involved to really try to kill the virus. So let's say somebody's exposed to COVID for the first time, then the cells in the nasal passage, the mouth, the lungs will expose the virus on the surface of the cells, and they will expose them to so-called naive T cells and B cells. So these cells have never seen virus before, and once activated by the exposed virus on the surface of the cell, they will rapidly expand, meaning they'll produce thousands, millions of cells that are designed to eliminate the virus. And that takes several days. And the maximum response is between 7 to 14 days. And that's when your COVID test will be positive, right? You're producing like at least in the initial few days, you're there to generate antibodies and killer cells to eliminate the virus, which in the context of a first-time exposure would take place 10 to 14 days after exposure. And then your normal immune system is designed to contract, means that it recovers, the virus is gone, and you're left with memory B cells, so that if you're exposed again, these cells can quickly come up and produce antibodies much quicker, and T cells within a few days, as opposed to a couple of weeks. So to recap, there's two types of immune cells. The B cells are there to produce antibodies, and the T cells are there to produce killer cells that will eliminate virus by killing the infected cells. And these cells and antibodies are important because once they're produced, what they're going to go in the lung, they're going to go into the nasal passage and your oral cavity and be a first line of defense for COVID. And they will result, if you have high level of antibodies, they will result in rapid clearance of the virus. So they are very important for local immunity. Now, I said, B cells are important, but specifically naive B cells are very important in generating new antibodies to COVID. So the first exposure, the first vaccine or the first infection, your naive B cell in the blood or in the nose will travel to the surrounding lymph node, will generate these new cells with the aim of producing highly specific antibodies to COVID. And you're left with plasma cells and memory B cells. And then once you get a booster or a second exposure, then it's these memory B cells that could go back, travel to the lymph node, and their goal is to have ultra specialized antibodies. So in the case of a original vaccine, in case of the Pfizer vaccine or Moderna, the original one, a second vaccine would result in highly specific antibodies to the original strain of COVID. So there's an imprinting into that booster effect. And those highly specialized antibodies have a higher capability of neutralizing the virus. So that's normal immune cells, normal immune system. But we all know that patients with lymphoma and CLL have compromised immune systems. And this resulted in a very high mortality due to the original COVID wave. But we think that a lot of this mortality was due to the hospitals being at overcapacity and being overwhelmed by something new. The mortality original reported was around 23 to 34%, multiple different groups. But a multinational, international study looked at the incidence of mortality in patients with hematological malignancies after the first wave and before Omicron, and we saw that it was around 13%. So still higher than the average population, but lower than what we observed in the first wave. And what we noticed is that other than having impaired immunity, active disease, and being on treatment, having advanced age or being of male sex were risk factors for higher complications and death due to COVID. So what about vaccine responses? We know that patients with CLL have an inferior or a poor response to vaccine. And really the pioneering group in this field comes from Israel. They had the first access to the Pfizer vaccine. And what they did is they measured the amount of antibodies in the blood of patients with CLL that had the Pfizer vaccine after 2 doses. And what they showed is that if you look on the left-hand side with the blue and the red bars, that the patients with CLL had about half of a response, antibody response to healthy controls. However, if you looked at the actual antibody levels in the blood, we note that the patients have very few antibody responses. So even though they have detectable antibodies in the blood, so as a yes, no, are there antibodies to COVID, the fact is that these patients, the levels that they had were nowhere near what normal healthy controls had. And then when you look at the patients in more detail, the patients who had the best responses are those who were off therapy and in remission, while those who are ongoing therapy or treatment naive, meaning before therapy, had inferior responses. And certainly patients who had exposure to antibodies, so-called rituximab or obinutuzumab, so that target B cells, within a year had a very poor response to the vaccine. This is also true in patients with lymphoma. So the same story, those who had been exposed to anti-CD20 antibodies, who are undergoing active therapy or even treatment naive, had inferior responses to healthy control. So as you see in the red square here, but active therapy for sure had like no response, no antibody response within 2 weeks. And it really appears to be a year where, the recovery of B cells is required to start producing antibodies to COVID. And Other risk factors also are important in producing a vaccine response, and that's older age, having low lymphocytes in general, and like I said, active therapy and exposure to anti-CD20 antibodies. So why is that? So I am a hematologist in my hospital, and I work in the clinical lab, and I can measure the number of B cells in the blood of my patients. I do that by using a test that allows me to detect lymphoma in the blood. And what I routinely see is that patients who have lymphoma and CLL have actually very low to no normal B cells in the blood. So what you're seeing here on the screen are so-called dot plots. So normal B cells can either be kappa or lambda. So there's two types of B cells, and they're normal. And having a normal distribution would be about half and half. So as you see on the left-hand screen, you see these purple dots that go into both either lambda or kappa. But what I want you to focus on or appreciate is that in the patients with lymphoma, in the middle one, all of the B cells are in the lambda. Those are the lymphoma cells, but there's like hardly any kappa. The same thing with patients with CLL. The big red dot are all CLL cells, but there's like no normal lambda cells. So my question that I had last year was, is it possible that the reason why patients with CLL or lymphoma that haven't been treated, that those who don't respond to the vaccine is because they don't have normal B cells to produce the antibodies? And so we looked at this in patients who were either on observation or have been treated previously with rituximab, and compared them to normal controls, which were the physicians and nurses at our hospital. So we were slightly younger than our patients, so we had to take that into consideration. But what I want you to appreciate is that the normal B cells in the blood, so CD19 is a marker for B cell and CD4 is a marker for T cells. And so in the normal controls, it was around 200 versus it was less than half of that for those who were on observation and those who had prior lymphoma therapy or prior rituximab use. And in terms of T cells, the patients who were not treated had just a slightly lower T cell count than normal. But really the T cells become impaired with patients who have been treated with chemotherapy. So chemotherapy can decrease the T cell count, but the recovery of the T cells is much quicker than that of B cells. And what was another interesting finding of this study was that, in fact, 13 to 16% of patients had anti-COVID antibodies in the blood before their vaccines. So in fact, we overestimate the responses to vaccines in some of the study because we think that the antibodies that we're detecting are from the vaccine, but in fact, they were probably from a previous COVID infection that the patients were not aware of. So when we look at the timing, of the antibody production and the B cell recovery in those who had prior exposure to rituximab, we see that for sure a year is a minimum as to where we see B cell recovery. What we're looking at here, each dot represents a patient. The blue dot is the level of antibody production, with the dotted line being the level that we would see in normal B cells. So you see the B cells, the antibody production in the first year is very low, and then it starts to recover in the first and second year. And in fact, some patients really have a hard time recovering the B cells, even beyond 2 years. And some of these patients had been treated with CAR T therapy. So that results in prolonged B cell depletion. So both just the exposure to rituximab and having low B cells in the blood were both predictive of response to vaccines. So one can argue, well, if I don't have any B cells, can my T cells prevent COVID? And the answer to that is yes. So there are studies looking at patients who fail to generate antibodies to COVID, but are able to present to have a T cell response. And in a couple of studies, what we were able to understand is if we take the T cells from these patients and expose them to COVID spike protein, then we're able to measure that these T cells remember they have seen COVID and they can generate a response. Yet the response is still not the same that we would expect in normal, but there is still some response. So what about additional doses? And in this study, we measured the effect of antibody production in patients with CLL, lymphoma, and multiple myeloma after their third dose, so their first booster. And what we've learned from this study is that if you get your boosters in the context of recent treatment, it won't be effective. If you were able to generate antibodies after your first 2 doses, then having a third dose will definitely boost your antibody levels. However, if you got the first 2 doses in the first year of therapy, so ongoing chemotherapy, and then you got your booster within that first year of having been exposed to rituximab, then the chances of responding to that third booster is very low. Yet some patients are still able to generate T cell responses. So just because you don't have B cells doesn't mean that T cells are not working. So Omicron changed everything last January. And the reason for that is that this new virus strain was able to mutate, and the changes conferred some survival advantages for this virus. It was able to avoid immune evasion from some of the antibodies that were produced by the vaccine and the original infection, and it was more infectious. So it was more stable. It was always on the active conformation, and it had increased viral attachment, so it stayed on the cells longer. Ultimately, it resulted in a very big wave where most of the deaths were seen in patients who were unvaccinated. But there were still a lot of patients that, with CLL and lymphoma that had, severe COVID from this. The question was, at the time, could a booster using the original vaccine help? And there's a British study looking at over 2 million people. And in fact, it did show that having 2 doses of vaccine and a booster using the original strain, it can provide for 20 weeks, so 3 to 4 months protection against Omicron. But Omicron, that was last January. Now we're dealing with new variants, and the most prevalent variant currently is the BA.5 variant that is responsible for 91% of the infections in Canada. This was data just taken from the COVID site, Health Canada site just last week. And as you could see on the right-hand side, the peak in January was really that's where most of the infections occurred. And we're nowhere near what the levels of infections that we had in January. So COVID has evolved, and what you see on the left are the original strains, including Delta. And then Omicron is completely on the right, so very different from the original. And we are now dealing with the BA.2 variants, so BA.4 and 5, which is really more infectious. So given the new variants, there are opportunities to update the vaccines, and we do have two new vaccines available. There's the one from Moderna that has been available for some time, which uses the genetic code of the BA.1 original Omicron as part of their recipe, and the new Pfizer that is targeted against the BA.4 and 5 that has been approved on October 7th and available as of this week, actually. So the question is, do these new vaccines matter? Are they able to protect us against these new variants? And so the way to answer that is to look at responses of the fourth dose, the original strain of Pfizer and Moderna, at their ability to kill new variants. So this is a study that was taking blood from patients with CLL and lymphoma who have had their fourth vaccine booster, but with the original strain. And what they did is they measured the ability to kill viruses before their fourth dose. So that would be the dark blue bar. So that's the after vaccine 3, and after their fourth dose, which is the white bar. So we could see that in these patients, there is a little bit of an improvement in targeting the HU1, so the original Hunan variant. But if you expose the antibodies to the new variants, the original Omicron, BA.1, or the new variant BA.4, it was not 4 or 5, we do see that having a booster with the original, then that provides some level of protection. So it is not just because there's a vaccine with the original strain doesn't mean there's no protection against the new variants. So that's with the original vaccine. What about the new bivalent vaccines? So this is hot off the press. It was just published last week, looking at the ability of the Moderna bivalent to kill or neutralize the Omicron. So in other words, these new variants, this study involved over 800 people, all of which were vaccinated against COVID using the original Moderna vaccine. And what they did is they separated this group into two groups. One received as a booster the original Moderna, and then the second group received the bivalent booster. And then they tested the neutralizing antibodies in the blood to see how well they were able to kill the variants. And what they found was, in fact, if you look at the bars, that in both cases, they're able to generate neutralizing antibodies to both the Omicron and the original strain. So that's good. It tells you that there is some level of protection, but that the ability to kill Omicron using an Omicron recipe in other words, using it in the bivalent, provided better protection for Omicron. So that's tells us that probably the bivalent is more efficient at killing the variants, which is what we would expect. The other interesting thing is that for people who have been exposed to Omicron naturally, so in other words, they've been infected with an Omicron or Omicron variant, we're able to generate a lot more antibodies than the others that had no prior infection. And then the other thing we've learned is that there is some degree of imprinting in that even though we're able to generate better antibodies to variants, we're still much better at producing antibodies to the original strain. So because the original strain is what your body has been trained to kill with all these boosters. So those are that's the data we have for vaccines so far. What about therapeutic antibodies, antibodies that are produced commercially in the lab to treat COVID? Well, there are many that have been on the market. Unfortunately, most of them are no longer effective against the variants, with the exception of the Evusheld that has some activity, which I'll describe here. So Evusheld is an antibody mixture, like an antibody cocktail developed to treat and prevent COVID. It was designed to have a prolonged half-life. Again, it was designed against the original BA.1 strain, so the first version. And it was tried on healthy people after the original wave and before Omicron. And the results of their large study showed that there was symptomatic COVID in 8 out of 3,000 patients with the Evusheld, but in 17 out of 1,700 in the placebo group, so 0.2% versus 1%, with a relative risk reduction of 77%. So based on these data, it was approved for patients who are immunosuppressed or unable to generate their own antibodies. So is this effective? So what we see on the right is, the ability of these antibodies to kill the different virus strains in patients who've received Evusheld. So in patients who are immunosuppressed and unable to generate their own antibodies, they get the Evusheld, you take their blood, you measure, you put it in a petri dish and see how it can perform at killing the different viruses. Well, if you look at the first column or first bar, you could see that those antibodies are super good at killing the original virus, 100% kill. However, the new variants, the original Omicron and the BA.4 have less activity. So it's not zero, there is some activity, but you could see that it's not as performant as targeting the original strain. So that's a treatment option that can be useful in some patients who we feel are immunosuppressed or don't have a very good antibody response, but to prevent COVID. What about if patients actually get COVID? Then there is supportive care. And for those patients, those who are really sick, in the ICU, then we offer anticoagulation and steroids. Although I have to say, after the Omicron wave, we see very few patients with COVID. In our hospital, we don't have any patients who are in the ICU because of COVID. And then there's antivirals, and there's two that we use, remdesivir, if there are symptoms for less than 10 days, and Paxlovid, if there's symptoms less than 5 days, and an outpatient. And that's really what we offer to our patients. So the take-home messages of this talk are threefold. That one, the patients with CLL and lymphoma are vulnerable, and they are vulnerable because they have low level of B cells. They're vulnerable because their immune system is hijacked by the lymphoma and not able to produce normal B and T cells, and from their therapies that also impair their immune response. And the antibodies that we can give them therapeutically last about 3 months. We can prevent COVID. In the hospitals, we're still using social distancing and masks to protect our patient populations. Vaccines are recommended and certainly are more effective the further away the patients are from their therapy, especially anti-CD20 therapy. There is Evusheld for patients who think they're going to have a high risk of being exposed to COVID. And so I think a good strategy that I recommend to my patients is to use Evusheld, a couple of weeks before they think they're going to be exposed on a trip or a Christmas vacation, for instance. And then there's treatment options for patients who are infected with COVID, the most common being Paxlovid. So to not delay getting tested so that they could get the treatment. And there's also remdesivir. And there's ongoing research to try to find novel therapies for our vulnerable patients. So that was what I had discussed today. I hope I didn't take too much time.
Awesome, no problem. Thank you very much for your excellent presentation. And we just have one really quick patient question that has come in. So now that masking and almost all COVID-19 restrictions have loosened, what should lymphoma and CLL patients do to continue to protect themselves over the next few months?
I think that that vaccination is important. I think that to avoid people that are sick, so masking is important, and from that perspective, but really we recommend vaccine, Evusheld if we think that there's going to be a high exposure risk. For instance, one of my patients is going to a conference, and I said 2 weeks before the conference, consider vaccine or Evusheld, and there are treatment options. Unfortunately, there's, we can't change the fact that there's going to be more people being exposed, having no mask mandates and no social distancing.
That makes sense to me. Well, thank you everyone for joining today. Please stay tuned for the next session on Lymphoma 101 starting in a few minutes. I'll see you then.